But a lot of the efforts have been made to improve the patient experience for these treatments, as they can be given for years at a time. So, for example, when leuprolide debuted way back in 1985, it was a daily injection. But 4 years later, they developed the monthly depo formulation. And then now we have formulations that are approved for administration once only every 3, 4, and even 6 months. So big difference from what it used to be.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Andrew Ruplin, Clinical Oncology Pharmacist at Fred Hutchinson Cancer Center in Seattle, Washington, about the LHRH Agonist and Antagonists drug classes. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome back. Thanks for joining us again today, Andrew.
Thank you. Glad to be back.
So to start, can you give us a brief overview on the history of LHRH agonists and antagonists in the field of oncology?
I spoke in the recent episode about CYP17 inhibitors and prostate cancer about how we have understood since the 1700s that prostate size and health is related to the testes. But the knowledge about secondary sex characteristics in testes is actually a lot older than that. And I was doing some research, and apparently even going back to the 1st century, there's documented evidence that castrato singers existed even back then. So this has been very, very old thing. For breast cancer, though, have also known, at least for some amount of time, that there's a clear connection between the ovaries and development of breast cancer. And when I was doing research, I found that really the first reported case that I could find was published by the physician Sir George Beatson in 1896. And you can actually go find his article still. It's published and it's online on PubMed, describing a patient with premenopausal metastatic breast cancer. So, still quite a long time, over 100 years at this point. Our contemporary understanding of sex hormones and how they relate to cancers of the prostate, breast, and reproductive organs are based on the huge amount of work done in the 1900s, which ranged from synthesis of testosterone in 1935, identification of estrogen receptors in 1958, and then many more decades of work that led to the first FDA approval of an LHRH agonist in 1985, leuprolide, or as how I always hear it said, leuprolide. Since then, other LHRH agonists have been approved, albeit not all with the same indication. So there's histrelin, goserelin, triptorelin, and then several others. LHRH agonists were first approved in the early 2000s, with the most recent, relugolix, receiving approval in 2020 for prostate cancer. Between all these agonists and antagonists, there's a broad spectrum of applications, including hormone-positive breast cancer, androgen deprivation therapy for prostate cancer, uterine cancer, and then other non-cancer uses like uterine fibroids, endometriosis, and assisted reproduction fertility treatments, and other things too. Last point I'll say about this history is that the naming conventions are consistent. So LHRH agonists always end in relin, and antagonists end in lix, L-I-X.
It's a very handy little trick to tuck away there. Thank you for sharing that. And thank you for sharing the history. I always find it fascinating. So let's talk about the general mechanism of action that is associated with both the LHRH agonists and antagonists. Can you describe that in a little bit more detail?
The end result of complete inhibition of estrogen or testosterone at the level of the ovaries or the testes, respectively, is the same between LHRH agonists and antagonists. But how they achieve this end result is a little bit different. So in a person with a functioning gonadal pituitary axis, the hypothalamus produces and secretes luteinizing hormone release hormone, or LHRH, also called gonadotropin release hormone, or GnRH. You see them used interchangeably, to the pituitary gland, which then secretes follicle stimulating hormone and luteinizing hormone. So that's FSH and LH. We got to keep all these acronyms in check. LH and FSH, and the testes and ovaries produce their respective sex hormones in response to FSH and LH. When they produce these hormones, this is a negative feedback loop onto that axis. So production of estrogen and testosterone ultimately decreases production of more LHRH in response to the excess sex hormones. And they increase production of the LHRH during deficiency of the sex hormone. So they're constantly feeding back on each other in a cyclical fashion to increase when there's deficiency and decrease when there's excess. LHRH agonists basically hijack that process. So initially, when you give a patient an LHRH agonist, it causes a surge of sex hormones brought on by the fact that you had an increase in the LH and FSH from the pituitary gland. And then continued administration of an LHRH agonist produces downregulation of the LHRH receptors, which cause an inability to produce more LH and FSH, which then ultimately causes decreased production of those sex hormones too. It also causes desensitization of those gonadal receptors for LH and FSH as well. So without this stimulation, the testes and the ovaries just stop producing sex hormones. Conversely, the antagonists, and this is kind of a lot easier to describe, the antagonists, by contrast, are a competitive occupier of the LHRH receptors. So if you block those receptors, it just stops production of FSH and LH from the pituitary gland. There's no surge in hormones because you're using the antagonists, because you're just blocking that production. It's going to shut it down. So there's no surge. There's also some studies out there suggesting that LHRH receptor expression may decrease as well, also during antagonist therapy. So it may not actually be as simple as receptor blockade, but for educational purposes, that's usually how I describe it. One of the key points about both mechanisms is that these processes are reversible. So hormone production will resume after you stop the treatment.
Well, as always, we've talked about cascades and negative feedback cycles before. Like, in my mind, I'm building a picture, and your explanation is very comprehensive, and it really does help connect those dots for me. So thank you so much for giving that very thorough explanation, because as you said, a lot of letters, all the same letters talked about, but very different and very discrete actions. So I really appreciate you taking the time to walk us through that.
Yeah, pictures help. Pictures always help.
So can we talk a little bit more about maybe some of the primary subclasses of the LHRH agonists and antagonists, and maybe you can highlight a few examples of some of the newer or more well-known agents?
So I actually think of the LHRH agonists and antagonists as subclasses themselves, since there's often a big overlap, if not almost basically total overlap, between their roles in the treatment of disease, but most especially prostate cancer. There's not really been any dramatic changes in the overall pharmacology of this class since its inception way back in the 80s. Actually, it feels weird saying that way back in the 80s now, but
it doesn't feel that long ago, but apparently it's 40 years.
Almost 40 years ago. Yeah. But a lot of the efforts have been made to improve the patient experience for these treatments, as they can be given for years at a time. So for example, when leuprolide debuted way back in 1985, it was a daily injection. But 4 years later, they developed the monthly depo formulation. And then now we have formulations that are approved for administration once only every 3, 4, and even 6 months. So big difference from what it used to be. There are also intramuscular and subcutaneous formulations of leuprolide that'll become a little bit relevant. We'll talk about in a little bit. And it's worth pointing out that the antagonists are largely relegated to prostate cancer indications only. I'm not actually aware of any antagonists that are approved for breast cancer or gynecologic cancers, possibly owing to the existence of highly efficacious direct estrogen receptor modulators and degraders like tamoxifen and fulvestrant, and then the aromatase inhibitor class, which decrease estrogen through a totally separate mechanism than what we're talking about today. So any of that tamoxifen, fulvestrant, aromatase inhibitors, not LHRH mechanisms at all, but they are hormonal therapies that we see used in breast cancer and some other cancers as well. The newest LHRH analog is relugolix, which again is an antagonist. It's got that LIX name. And the first and only form of oral androgen deprivation therapy for prostate cancer. So that was a really big deal for us. It is taken by patients once daily after a loading dose on the first day. It is a high-cost agent. So at our center, we check for prior authorization for all patients. And it usually has to be dispensed from a specialty pharmacy. Because it is hepatically metabolized, drug interactions are possible with other medications that alter activity of the CYP450 enzymes, which is basically not really relevant for any of the injectables like leuprolide or goserelin or even dagerelix, which is the injectable antagonist.
That's really interesting just to recognize that now it's not just injectable, but oral forms, and just kind of following that through to the patient and how that would change our education for our patients and following and monitoring their adherence to therapy. It does sort of just put a nice little twist on that therapy for patients and important. And I'm glad you brought that up. What are some of the common toxicities and adverse events that we commonly associate with the LHRH agonists and antagonists, both as an individual agent or as general subclasses?
So owing to their effects on the sex hormones and ultimately as the sex hormones, the side effects that do develop or can develop tend to be slower, sometimes occurring over months, but can last for years or simply as long as these analogs are continued. The side effects can be very diverse themselves as well. So how they manifest is also somewhat different between male and female bodies. And in the education of my female patients, I basically use the analogy that it is functionally inducing menopause in that person. So there can be changes to mood and cognition, energy level, fatigue, body morphology, and shifts in fat distribution, metabolism, which can unfortunately increase the risk of cardiovascular disease. One that almost everyone's familiar with is hot flashes, but also changes to bone mineral density, libido, and physically too, atrophy and dryness of vaginal mucosa, which can make sex for our patients more difficult as well. In our males, they can effectively have all of those side effects as well, but also some things that are sensitive to some people. So there can be enlargement of breast tissue in males, shrinking of the testes, and then erectile dysfunction as well. Personally, I find that hot flashes are the most common toxicities that I hear complaints about from my patients, both male and female patients. It's worth pointing out, too, that the antagonists have some evidence of lower risks to cardiovascular health. And an analysis of patients in the HERO trial, which led to the approval of relugolix, so they compared relugolix and leuprolide as androgen deprivation therapy for prostate cancer, did show a major, or what we call a significant difference in major cardiovascular events between those two agents. While it may seem obvious, pain at the injection site for these agents is a common complaint of patients, not surprising. But we do know, I guess more so based on some of my experience, that some of the routes of administration seem to make a difference. So a few years ago, there was a shortage of intramuscular leuprolide, and we used the subcutaneous formulation preferentially to help manage our stock. And some patients complained the pain from the subcutaneous injection was basically so bad that some patients were like, I don't want to do this again. Use the intramuscular. I can't do this. And really frustrating that you can try and pre-medicate for pain, I suppose, but I didn't have a good explanation for why one hurt so bad and the other didn't. The subcutaneous, I think, is refrigerated basically up until the point of administration. Maybe that coldness hurt, but really frustrating for patients. One kind of final point, too, is a concept that's familiar to all professionals in the care of prostate cancer, is that because LHRH agonists cause an initial increase in testosterone, which can kind of, in essence, feed the cancer, some patients can experience worsening symptoms of their cancer, such as difficulty voiding their bladder, pain, or even vertebral collapse or spinal cord compression when bone metastases are present. This is a really serious issue that should be considered ahead of starting an agonist in these patients. And again, worth pointing out that it does not occur with the antagonists because there is no sex hormone surge.
That's really interesting. I think it is unique, just the differences in sub-Q versus IM injection and how those were experienced differently for patients. That is something worth considering, and definitely an education point to provide to patients ahead of time if they do have to switch their administration for any reason. I think that's important to give them that heads up and awareness so that they can at least be anticipating that and be ready for it. But that is interesting. I wonder why that happened. Maybe somebody will explore that and share their findings, somehow publish that so that we can all learn on behalf of them. So what are some of the pharmacology-related strategies used to prevent or manage some of these toxicities?
So the strategies to manage toxicities are about as diverse as the toxicities themselves, but I kind of frame it as it really kind of resembles management of chronic illness unrelated to cancer. So, for example, for our patients who are on long-term LHRH analogs, we should monitor bone mineral density. We often have them start calcium and vitamin D supplementation, and we may need to use a bone modifying agent to preserve density and prevent fractures in those patients, just as someone who did not have a diagnosis of cancer would have to do. Patients with changes to their lipid profile also, for example, might require statin therapy. Medications to treat erectile dysfunction are available, as are local hormonal treatments to alleviate vaginal atrophy and improve lubrication. Hot flashes are probably the most frustrating to treat, in my opinion, because selection of a medication to treat hot flashes can depend on things like drug interactions, individual organ function, and patient sex. and not all patients will get adequate relief, and hot flashes are a purely subjective side effect to the individual. So it can be difficult to treat in those cases when patients are like, well, I'm getting some relief, but I'd like more. What can we do in addition to that or in place of that, right? Can we absolutely eradicate hot flashes in all patients? Unfortunately, not in every, right? Serotonin uptake inhibitors like venlafaxine have evidence for treating hot flashes, as does gabapentin and kind of curiously oxybutynin, which is used for bladder indications. But those three have some decent evidence and experience behind using them as well. When I alluded to before, when I said the sex of your patient can matter, in male patients, we have evidence that we can use medroxyprogesterone or cyproterone or megestrol or Megace, as it's sometimes called, for use in male patients. The tumor flare phenomenon I described earlier is managed by having patients start an androgen receptor inhibitor before or at the start of their LHRH agonist treatment, and usually continuing it for at least 7 days, but more often, sometimes several weeks while we wait for their testosterone to fall.
I know we've talked about before just the notion of hot flashes. And, in my experiences, I always tried to just encourage patients to talk about it and let us know that they're experiencing them. I think there's sort of this misconception they just have to deal with it. I don't know if that comes from just, hot flashes related to menopause and just the sort of maybe anecdotal expectation that like people they knew who went through just dealt with it. So we just got to deal with it. But I think it is important, as you mentioned, that there are options. They might not all work perfectly, but it is something that we need to encourage our patients to talk about and report to us so that we can try some of these pharmacologic strategies to help minimize as much of discomfort related to hot flashes as possible, because it has a huge impact on quality of life. So what administration considerations should nurses keep in mind for when they're administering these agents, the LHRH agonists and antagonists, to their patients?
So if your center carries different LHRH agonists and antagonist injectable routes of administration, please double check that your injection is going into the correct tissue. I know nurses do checks and double checks as part of their process, but these products are simply not interchangeable for those different tissues, and they need to be given properly. So depending on how your center dispenses them, it may say leuprolide and it may just put in smaller font next to that, IM or subcutaneous, right? So it is really important that we are absolutely checking routes of administration and all those things that nurses do on a daily basis. Our center had a large preference for the intramuscular product. So when we had that shortage, just to think about additional things like what can we do to support our nurses and support our patients, we made sure that our nurses received education that this temporary process change was being implemented, and they may see less of the intramuscular, and they need to be really aware that they're using the subcutaneous product if they have one. If your patient is on relugolix, so that oral one, the FDA and the manufacturer do recommend a reload. It has a 1-day load followed by just maintenance dosing after that. But they do recommend a reload if your treatment has been interrupted for more than 7 days.
That's really interesting. And again, I appreciate you pointing out just that they're not interchangeable, the IM versus the SQ. And if your institution is experiencing a shortage or having to switch between those agents for any reason, it's really important for nurses to look carefully at the order, understand what agent they're giving and what is the administration route, because it matters. It matters for efficacy. It matters for absorption, for all of those things. And so just really important. But hopefully when those things occur, they are not one-off for a single patient, but more something that is happening across all patients receiving a drug. So hopefully the communication would be consistent for that, but just an important point to drive home. So what are some of the primary patient education points that you recommend, we communicate to our patients and their caregivers about LHRH agonists and antagonists?
In addition to the toxicities I discussed before, I think it's important for patients to understand that because they may be on these treatments for months to years, some of these side effects may be relevant to them likewise for years, or also in my prostate cancer population, they may be on androgen deprivation therapy with these agents for the rest of their lives, and they may have these side effects for the rest of their lives too. And while I described some of the pharmacologic approaches to toxicities, of course, I'm a pharmacist, I'd like to recognize and advocate for the importance of lifestyle changes and support as a component of their care as well. So nutrition, physical exercise, and perhaps approaching physical intimacy in different ways than before than the patient may be familiar with. So if your center has a specialist in one of these relevant areas, I really think they should absolutely be included in the care of patients who are receiving these medicines.
Such an important point, and I appreciate you bringing it up. I do think for those institutions that do have those resources available to their patients and they are, part of the care team, it is so important to understand when to refer them to those partners in care. And sometimes it's a repeat referral. Sometimes they're referred for separate things or distinct points in time. As you mentioned, these side effects, these adverse events can last for as long as they are on these agents, or they can show up in a distant time relative to when they started. And so just always important to keep in mind what resources are out there for patients and always taking the opportunity to reinforce, as you mentioned, healthy lifestyle changes and habits that can have an important impact on the quality of life that they're experiencing, as well as being able to manage some of the adverse events. So I appreciate you pointing that out. So, Andrew, how do you see pharmacists and oncology nurses collaborating to help manage adverse events and toxicities, provide patient education, and just to serve as a trusted source of information for our patients?
At our center, patients receive a dedicated visit with a nurse or a pharmacist simply to discuss education about their treatment. Of course, the providers and physicians and our advanced practice providers may discuss with them, but at their decision-making visit, but we have our own dedicated visit for them to just get education and ask questions and things like that. But as you can imagine, with all of the long-term side effects that can affect lifestyle or short-term, long-term, et cetera, these 30 or 60-minute visits can't encompass every single thing that you ideally like to discuss. And to be quite frank, I don't always feel knowledgeable about more in-depth discussions about topics like nutrition or intimacy. I personally, to give a little story, I was fairly recently put in the position of a caregiver receiving education because my dog, everyone here pretty much knows I have a Pembroke Welsh Corgi. I've had him for a long time. I love him. But my dog required a tooth extraction under full anesthesia, and there were some post-surgical instructions I had to follow for about 2 weeks. And it was really interesting for me to reflect on how much verbal education I was actually able to retain, even as a healthcare professional. And I do remember that I initiated my own teach back method to see actually, what things I had correct about this care. And I was really thankful for written handouts to remember all the different aspects of my dog's care. And while it sometimes feels silly for me to hand sometimes 10 or 20 pages of information that I already consider to be distilled down from even bigger and more intimidating references, I do really realize how important written education is for our patients. So whether it's nurses or pharmacists providing education or perhaps both, I really think cancer centers should always offer accurate and up-to-date written educational resources for patients. And at our center, again, whenever we're developing our own internal education resources, we have representatives from pharmacy, nursing, nutrition, lots of different professionals all weighing in on these education resources for our patients.
Such a great point you bring up. I think for any of us that have found ourselves on as the patient or as a caregiver, it does always offer a very unique and informative perspective on just, when we are performing the role of the clinician, how that can come across. And so, again, not always wanting to have to be in that position, but I think we all at some point in our lives will find ourselves on the other side of healthcare. And so it does always provide that opportunity to kind of reflect on how we perform our education, what we provide to our patients and their caregivers. And I think definitely does bring some of those things to light. And as you mentioned, I think offering patients, whether it's written education as a resource, but also understanding if there's other ways that they learn best or prefer to learn, the more that we can provide options for all of those learning styles, the better we are for patients. And as you said, sometimes it feels like we're just shoving them a giant packet of handouts and sending them on their way. And so I think there's context to deliver with that as well of, helping them understand, this is not homework. You don't have to go home and read it all tonight, but just informing them that, things that we've discussed are included in here as reference and just giving them that reassurance that they don't have to remember it all. We expect them to still have questions that pop up later and always being available and making sure they understand who to call and how to get in touch with the care team if and when those questions do arise.
Absolutely. Yeah. We're even doing some video education resources on topics like nausea, diarrhea that can be applicable to patients with diagnoses throughout the entire clinic. So the diversity of the resources too is evolving, and I really admire that.
Especially in this patient population where they maybe are only coming every 3 months, maybe even 6 months to get their injection. That span of time, not having connection to their care team versus when you look at infusion therapy, radiation therapy, other modalities where they're here every day or every week, it just, again, puts into perspective how those patients might need a different way to receive their information, their education, and also different attention given to them, when they do come back to clinic, because their visits with us are less frequent. And so they might have more questions or more gaps to fill in terms of things that have come up in those past 3 to 6 months. So all really important points, certainly to this population and these drugs, but also I think beyond that. So Andrew, what do you look into your crystal ball? What do you think the future looks like for these agents and their role in the cancer care landscape?
I think it's important to understand where we've been before we talk about where we go, because a little bit topsy-turvy, I think. So these agents were some of the largest breakthroughs in setting a new standard of care for advanced prostate cancer. And since then, they've basically always formed the backbone of systemic therapy for these patients. Androgen receptor inhibitors or CYP17 inhibitors and chemotherapy were all studied and approved in addition to LHRH analogs in that prostate cancer population. But what I'm talking about when I say topsy-turvy is that some recent publications have demonstrated that maybe not all patients need to receive androgen deprivation therapy with these analogs if they're receiving abiraterone or enzalutamide. Specifically, those are 2 trials. So there was SPARE trial and EMBARK trial. And so if anything, we've maybe just stepped back a teeny bit in terms of the future of these treatments. But overall, these are not going away anytime soon for prostate cancer. So they're going to be with us for a long time still, I think. I don't think we'll see any dramatic changes in treating breast cancer, since the role of these agents is a lot more limited and simply really exists to suppress estrogen in premenopausal patients. But as a referral center that routinely sees patients with breast cancer in their 40s and 30s and even their 20s, it's crucial to consider these agents in their role for not only actively treating certain types of breast cancer, but also in preserving fertility for patients who desire to have children and they are receiving gonadotoxic chemotherapy.
Certainly very important things to consider. So, I agree with you. I don't think that we'll see any major dramatic drop off of these agents. We might be taking a closer look at who and how and when we use them. But as you mentioned, all the great history and how we got to where we are today, it's something that we will continue to see as we care for our patients, probably for quite a while. So Andrew, thank you so much for joining us again today. It's always a joy to talk with you and really get into the nitty gritty about some of these very intricate feedback cycles and things, but really help to make sense and to connect the dots for me. So I always really enjoy speaking with you and talking about these subjects. As we reach the end of our episode, we always like to review a quick series of questions to help summarize the things we've talked about. So we'll start that off with, how can healthcare professionals evaluate their hidden or implicit bias about LHRH agonists and antagonists?
Especially in prostate cancer, which I kind of alluded to before, it has the most approvals for different LHRH analogs. I think we should be soliciting patient input about their preferences for how they wish to receive this therapy and not simply dictating it to them what we think they should be getting. For me, this includes considering how frequently a patient may want to get their injections, or if they don't want any injections at all, maybe they could consider relugolix. But then we also need to be honest with patients as their provider or their nurse or their pharmacist, whether or not you think that they are actually a good candidate for one of these given treatments. And of course, sometimes insurance drives some of these conversations as well.
What are some common misconceptions about LHRH agonists and antagonists?
I think some patients with prostate cancer may be concerned to hear that LHRH agonists could make their disease worse initially when we're referring to that tumor flare phenomenon that I talked about earlier. And maybe it makes them wonder about their longer term prognosis. But I like to reassure my patients that, one, we're going to prevent these symptoms with androgen blockade. So those spinal cord compression, worsening urinary symptoms, et cetera. And also that all evidence currently shows that the LHRH agonists, antagonists extend life by an equivalent amount. So I tell my patients again, we don't think that that tumor flare, even though in theory it might be feeding the cancer in the short term, long term, it doesn't seem to make a difference.
That's so important. I think it's probably a very common concern that patients have, whether they voice it or not, when that side effect or that symptom is described to them. So thank you for bringing that up. What's something about this topic that's not often discussed, but you wish people knew more about?
I talked about this just briefly a little bit ago, but sometimes we can and will use the LHRH agonist to preserve ovarian function in patients who desire to preserve their fertility during chemotherapy. And it's frustrating, to say the least, that because of the difficulties in studying fertility preservation in this population, there's not a huge wealth of data available that is convincing to insurance to pay for these treatments. And we often struggle to get these affordably for our patients without serious appeals processes. Our healthcare system already burdens our cancer patients with high expenses in the treatment of their disease itself. So additional asks for the cost of fertility preservation is no small ask either, in my opinion.
Certainly another among many other reasons, another reason why we should be bringing up the question and the discussion about fertility with our patients as early as possible, so that these wheels can be set into motion. As frustrating and cumbersome as they may be, the sooner we can start asking for the right things, hopefully the sooner that we can kind of get those approvals and move the treatment plan along. What additional training or education do oncology nurses need to stay current on this topic?
One practice I haven't talked about today is called intermittent androgen deprivation therapy for prostate cancer. So when we're doing this, certain patients start and stop their LHRH analogs periodically in response to basically how their disease responds or starts to grow again while they're off therapy. So they start it, we get a response, we stop them. The prostate-specific antigen, or PSA, which is a tumor marker for prostate cancer, if it starts to go up, we just start them back on the treatment. And in light of data I mentioned earlier about the anti-androgens being used without ADT, so again, the EMBARK and SPARE trials, enzalutamide, abiraterone, not all patients with advanced prostate cancer will be on ADT. So simply what I ask is, and I encourage nurses who work with prostate cancer to understand and ask their patients or understand the background of, maybe why is my patient with prostate cancer not on one of these treatments? I think it's important to understand the rationale behind why that may or may not be true.
And finally, what are some additional resources for patients or other providers who might want to learn more?
As always, I like to suggest to people, because I think they're underutilized to a degree, the National Comprehensive Cancer Network's patient guidelines on different cancers is a digestible but comprehensive way for patients to help understand their disease, their treatments, or their potential treatments, and how their disease might compare to other patients. I think it's a great resource. They are still long. And when I say digestible, I mean, we're still talking about probably 60-page long booklets. And I know I complained about 10 to 20 pages earlier, but I do think they are a great resource. But of course, I'll also say, I know because I worked on some of them too, that ONS has nursing and clinical practice resources, including educational handouts developed for patients as well. I think on things like sexual health and other things that are relevant to prostate cancer patients getting these analogs and whatnot.
Absolutely. Well, Andrew, thank you again for joining us today. It's always a great learning experience for me. I always learn a great deal when we talk about these specific drugs. So I really appreciate your time and your expertise. Do you have any final comments to share with our listeners today?
I just want to say thanks for having me on again so soon. And I know I probably sound a little biased, but I think a good complementary episode to this one is one that was recently published. So episode 321, Pharmacology 101, CYP17 inhibitors. So CYP17 inhibitors.
Wonderful. Thank you, Andrew.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.